Welcome to an hour of HealthMade Radio. HealthMade is a community for natural health seekers where we educate people about common health conditions and share extensive research on the most effective natural health treatments and promote legislation that protects our health freedoms. A core concept belief is in the innate intelligence and healing power of the body, and if properly supported spiritually, emotionally, and nutritionally, it can find its way back to health. HealthMade Radio will bring you information from integrative health experts throughout the world. Check us out at healthmade.co. Health is what you make it. I'm Dr. Michael Karlfeldt, and I will be your host. Today's guest is Jane McLelland, author of the groundbreaking book, How to Starve Cancer. Jane was diagnosed with cervical cancer in 1994 and did conventional treatment. In 1999, her cancer progressed to stage 4, and she started incorporating complementary and alternative treatments alongside chemotherapy. In 2004, she started developing leukemia as a result of the chemotherapy she received. Facing terminal cancer, with a little time left to live, Jane poured through research on old drugs with anti-cancer effects and put together a cocktail of off-label drugs and nutraceutical supplements in an attempt to block the pathways that cancer stem cells use for fuel. This metabolic approach effectively starved her cancer of its fuel, glucose, glutamine, and fat, and she healed herself. Jane is absolutely brilliant and understands cancer cell biology and off-label drugs better than most oncologists. I know you'll learn a lot from this interview. You may even find the breakthrough you're looking for. I want you to enjoy. Jane, it's such an honor to have you on the show, and I'm really excited. You're very welcome. So you were diagnosed with cancer. You followed the conventional treatment. And what did that do for you? What happened? What did that look like?
Oh, that was pretty horrific. I had a hysterectomy in 94. That was at the age of 30. So that was pretty, not only traumatic from a health perspective, but also emotionally and psychologically hugely devastating. I hadn't had kids at that point. I was 30 years old. And the children was something I always wanted to, I wanted a family. So it was a massive blow for me. And then obviously the chemo and the radiotherapy shut down my ovaries that had been left behind. So that was pretty awful. And I was very depressed, actually. I was really very low for a long time. And in fact, actually, it wasn't until I got my secondary, when it had spread to my lungs in 99, that I kind of snapped myself out of it, because I thought, well, I'm going to die now, so there's no point being depressed. I've got to get myself back into gear and try and address what the problems are. I had to do a huge mind flip just to try and get my head around the fact that I was suddenly in a very different situation, and focusing on my fertility was not something that I needed to do anymore. That was kind of now didn't really feature so much. So it was just saving my life at that point that was hugely important, because it was deemed terminal. Obviously, anything that spreads from one location to another part of the body is stage 4. And at the moment, current oncology does not have the answer for stage 4. So I knew that because my mother had died in 96 of breast cancer, and that had woken me up to the reality of where we were with oncology, and that it hadn't quite grasped the cocktails required, and the approach that really needed to embrace more of what was happening with the actual the cancer stem cells, and how they fed themselves and how they used energy. All of that was altered, and I knew that from the work of Otto Warburg that I'd studied way back, when I got my secondary, and when my mother had got her secondary, I started looking at the cancer metabolism and all the different ways that it behaves differently to normal cells, and it seemed to me that this area of cancer was being seriously overlooked. So I then set about trying to work out if there were ways to actually add on to the current, to the treatments that I was given by conventional means, just to see if I could make anything more effective. And I had no idea whether it was going to work or not. I was forging a new path. So here I am, thank the Lord, I'm still here. But I had no idea at the time whether it would work or not.
And this was right when you were diagnosed, when it had progressed to stage 4. This is when you start to look to see, are there other things that I can do along with the chemotherapy? That's right. Because you kind of lost. You realized that the medical profession really didn't have a solution for what you were dealing with, so you needed to find something more.
Exactly. And you get a lot of advice from the oncology profession to sort of not take any antioxidants and not look at Google, not look at, don't look at Facebook. Those things weren't really very accessible back then for me. But they are now. You have to be very careful where you look for information, because there is an awful lot of confusing stuff out there. And you can head off down the wrong path quite happily without realizing. But the point is that every cancer behaves slightly differently, and what one cancer type will feed on is not necessarily, it isn't the same for another cancer type. So melanoma, for example, behaves very differently to breast cancer or non-Hodgkin's or name any kind of cancer, and it has a specific pattern of the way. And this is something I've discovered. It became a little bit obvious to me when I had developed the leukemia. It was actually 2003, and it came back in 2004 again, because I didn't take my cocktail for long enough in 2003. But it seemed that I was controlling my cervical cancer with diet, but whatever I was doing for the diet for that one was not working for the leukemia, and I didn't realize that they have this different feeding pattern. And all of this research has kind of been emerging over the last 10 years or so, but it's still stuck in the research papers, and nobody quite worked out what was going on. It was only when I started writing my book that I was digging around, and it was obvious that every cancer had what's known as a phenotype, so it expresses itself, and the way it feeds is very specific. And this was fascinating to me, because this explained why I was controlling the cervical cancer and why I wasn't controlling the leukemia, because leukemia feeds mostly off a protein, so called glutamine, or a lot of amino acids actually, but the main one being glutamine. And it was behaving differently to my cervical cancer, which was behaving by eating mostly glucose. Not all cancers are able to sort of switch their fuels around. So if there's a shortage of one fuel, it'll switch to another. And this is something, again, that became more and more obvious as I was looking at, as I was writing my book and digging around and doing the research. And this led the development of what I now have, which is a map. It's kind of like a route map for people to try and work out how their cancer is behaving and what fuel lines their cancer is using, so they can work out exactly the kind of diet they should be following. So should they be reducing the glucose? Should they be reducing reducing their proteins right down?
So we have, we have now, a lot of people are either doing like the Gerson diet or the ketogenic diet. And what you're saying is that it depends on what type of cancer as to what type of diet that would work best for you. So the keto would not be specifically for all cancer types. It could actually be detrimental for some.
Absolutely, and I've seen that actually with prostate cancer. This is before it becomes castration resistant. So earlier on, whilst it's still responsive to androgen deprivation therapy, the cancer will actually not respond to a ketogenic diet. A ketogenic diet won't work, because actually prostate cancer thrives off fat, and fat is is a huge part of the ketogenic diet. And the same with melanoma. Melanoma actually thrives on acetate, and the BRAF mutation, which you often get with melanoma, means that it uses that pathway, and ketones are part of the ketogenic diet. So obviously the ketogenic diet is no good for melanoma either. But the Gerson therapy, which is very low in fat, works brilliantly, or not brilliantly, but it seems to have some good results for melanoma. Not many other cancers I've noticed, but melanoma it seems to have some results for. So it really does depend on your cancer type, and not just the metabolic phenotype, but also the genes will influence the way that it feeds as well. But it's important to understand that this area is not looked at by conventional oncology at all. It's entirely overlooked. So
great. Well,
this is an area I'm trying to lead a revolution and try and encourage people to look at and to try and look at what diet they actually need to follow. And it does sound a little bit complicated to start with, and there are probably words that a lot of people won't have heard of, like BRAF, and maybe they've heard of the ketogenic diet, maybe they've heard of the Gerson diet, I don't know. But it's new for anybody who's thrown into the cancer world, and they suddenly have to scurry around and try and find answers. It is terribly confusing with so many different options out there. How do you know which one is going to be best for you?
Yeah.
If you don't really understand how it works.
Yeah, and it's, I mean, with cancer exploding, and and obviously the oncologist and the research that's being done right now, it's not finding a solution whatsoever. I would love, when we come right back, we're going to take a quick break, and when we come back, I would love to hear a little bit more about this map that you were talking about that you developed for the patients. We'll take a quick break. You're listening to HealthMade Radio. I'm here with Jane McLelland. She's the author of the groundbreaking book, How to Starve Cancer. Welcome back to HealthMade Radio. I'm Dr. Michael Karlfeldt. I'm here with Jane McLelland, and we're talking about how to starve cancer using off-label drugs, things that your oncologist may not be aware of at all. And Jane has researched extensively in this area, and you've laid out a kind of a map, or I would say, do you call it like a metro map?
Well, I call it a metro map because I liken it to Piccadilly Circus. If the cancer, and in the middle you have a triangle, and each side of the triangle is either denotes carb, fat, or protein. Those are your three macros in the diet. So the three sides of the triangle is how your cancer tumor cell will feed. So it'll either it'll use a combination of all three, because it needs energy, which it normally gets from glucose, but it also needs building blocks to actually build the daughters. So it wants to keep on replicating and making more of itself. So it needs building blocks, so it needs fat, it also needs protein. It can manufacture that, but actually it also likes to just take it in as it's pre-made. And in fact, things like DNA, it's very lazy. It doesn't like making DNA. The cancer stem cell, if there's loose bits of DNA fragments floating around, maybe from chemotherapy, it'll scoop those up and actually just use those to incorporate into a new cancer cell. So sometimes you get a problem with chemo actually fueling, well, you often get that, sadly, where you get the chemo fueling a second cancer as a result of the fact that it's allowing the remaining cancer stem cells, which are not touched by chemo. These are slower dividing cells. And again, this is not fully understood by the oncology profession, that 1 in 10,000 cells in your tumor will actually just be a cancer stem cell. And these are slow dividing. They don't behave like fast dividing cancer cells. And they need a completely different approach. And this is where starving the cancer stem cell is really key. And this helps to eradicate that issue, which is, the reason why you get cancer coming back
And the cancer and the stem cells are the drivers, meaning that you have these fast replicating cancer cells, but if the cancer stem cells would not be there, there would be nothing that would be fueling these fast dividing ones, right?
Well, I think once you get the fast dividing cells, you have to kind of wipe those out. So I always think a little bit of chemo is useful. But you can also starve them as well. So you're starving not just the cancer stem cell, but you will be starving the voraciously hungry fast dividing cell. Because if they are dividing fast, they need that energy. They want to have that energy, and they will be influenced by the environment in which they're in. So this is critically important. So if you've got an environment where there's a lot of glucose, a lot of whatever it needs, the fat and the glutamine, just in that area, the cancer cell will just be, it'll listen to all the messages coming in to say, yes, this is a great environment to divide, and off it goes, dividing like crazy. But if there's an environment which is actually depleted of all those things, it then receives messages, and then it kind of switches itself off. And this is what you can do, and this is called epigenetics. You can actually influence the way that the cancer stem cell and the cancer cells behave just by influencing the environment around the cancer cell itself.
And you mentioned that each cancer type have different drivers, meaning that some, like you has the protein, the glutamine, that fuels it. Others is mostly the fat, and others is mostly glucose. So how do you how do you know? So let's say you have a cancer, you would then be able to look up and see what kind of fuel sources that the cancer would have?
Well, on my map, there's some slightly weird sounding names, and this is where you have to become a little bit. You don't get scared. Just look at the names and just accept the names for what they are. So there'll be things like mTOR, mevalonate, and words that most people would never have come across. But what you do is you type in your cancer, so say it's ovarian cancer. So you type into Google ovarian cancer, PubMed if you want as well, so that you actually go to the published medical articles, and then you put in the word phenotype, and then it'll bring up the way that it tends to feed. And as you trawl through, and what I also like people to do is actually add things like the words on each of my routes that lead into Piccadilly Circus, if you like. So mTOR would be one of them. Mevalonate would be another. So you add that word, or in fact you could add the drug. So say mevalonate you're looking up, statin drugs will actually block that. So you add that to your search. So you say ovarian cancer, and then you put the word statin in, and hey presto, bing, it'll throw something up for you, which will prove to you this is exactly what you need to be adding into your cocktail. Because, statins, in fact, actually ovarian cancer is very fat-driven as well. And statins are hugely useful, actually, for ovarian cancer.
Because a lot of people in the health industry, they're very scared of statins, because they feel that it has a negative impact on the liver and brain and nervous system and so forth. So actually in cancer, then, it can be useful?
Yes, and I think there has been too much negative press, because actually you will also find that it also is beneficial for the liver in some reports, and also it's beneficial even for Alzheimer's. But a lot of it is depending on the type of statin, because there's about 7 or 8 of them out there, and not all of them are very good for, so you have fat-loving ones, the lipophilic statins, and you've also got hydrophilic statins. And the lipophilic ones tend to be far better for cancer specifically, but also because the brain is fatty, actually it has an effect with... And a lot of these effects with statins are not just its sort of cholesterol-reducing effect. Some of it is to do with anti-inflammatory. Some of it actually stimulates. People don't understand that actually simvastatin will stimulate and encourage the immune system to switch back on as well. So there are a lot of benefits to statins beyond just reducing cholesterol. But this is not about reducing cholesterol in the whole body. You're actually just trying to reduce it in the tumour. So people say, oh, well, I haven't got a cholesterol problem, I don't need to take a statin. That's not the point. The point is that you have a tumour that is wanting to use cholesterol, and you take the statin to block that, and it's not specific to, trying to stop your whole body. It's actually a treatment designed to treat the cancer rather than a systemic problem.
Yeah, and I think that's important to understand that. You're dealing with a very specific health condition, dealing with cancer, and then you need to address that with the tools that are available. And cancer is something that is very adaptable, and it figures out ways to survive. So with your technique and with your research, you've then looked at all these different pathways. I mean, obviously, there may be more that we don't know of.
There are more. There are more than are on my map. But what I've done is there are a lot of ones that lead into those pathways on my map. So there are smaller ones, but I've tried to stick to the really key big ones, because that's what you want to do. You want to have what I call big guns, things that will actually hit those big pathways and actually just help to shut them down, so that you're actually getting maximum benefit. And a lot of the drugs actually that I have on my chart in my book actually will hit several targets. So statins, for example, they not just block the melanoma pathways, they also block the GLUT1, which is the glucose receptor that gets upregulated in cancer. So it has a dual effect there, but it also affects the PPAR gamma pathway, and it helps to improve the immune system, reduce inflammation. It has these other effects as well. So it is what's known as pleiotropic. It's got these multiple effects, and this is what a lot of these old drugs do, because they were, they're classed as being dirty in that they have multiple targets. Drug developers now try and have really focused, targeted drugs that just target one specific problem. But actually, the old drugs, some of the side effects are that they treat cancer. And this is what I exploited and what I discovered when I was trying to save myself, that you could, I could put together a cocktail of things that would help block it. And it seemed obvious to me that it was a cocktail that was necessary, because we have a cocktail for HIV. We certainly were developing that, or it had been developed by the time I was looking at it myself, not for HIV, but trying to save myself from cancer. And the whole issue of not giving a cocktail is beyond me. I can't understand why doctors don't realize it's such a glaringly obvious thing to me that we just don't use enough. It's a very complex condition, cancer. How can just a bit of chemo or a bit of radiotherapy possibly be the answer? It's nonsense. It's a complete nonsense. Cancer is a very complex, complicated disease. And I put in my book not just off-label drugs, but those are key. But I also put in a lot of supplements as well for people to use as well.
Yeah, and I see that here, like berberine and EGCG and curcumin and so forth. We're going to take a quick break. You're listening to HealthMade Radio. I'm here with Jane McLelland, and we're talking about a revolutionary way to deal with cancer. We'll be right back. Welcome back to HealthMade Radio. I'm Dr. Michael Karlfeldt, and I'm here with Jane McLelland. She's the author of the groundbreaking book, How to Starve Cancer. In it, she explains how to use off-label drugs and nutraceutical supplements to block pathways to deal with cancer stem cells and how to starve cancer that way. So we've been talking a little bit about some of the different off-label drugs, and also talking a little bit about what cancer feed on. But how, then comes the question, if I'm not supposed to have any glucose, I'm not supposed to have any fat, and am I not supposed to have glutamine and what am I supposed to eat?
Well, that is the question that many cancer patients ask. They get completely flummoxed by the situation they find themselves in, so they don't really know what kind of diet, because they look up their phenotype, if you like, so the pattern that the cancer tends to feed, and then they get a little bit lost as to what they can and can't eat. So certain cancers definitely feed more on, and glucose is something that I encourage most people to cut right down on, and have a low glycemic diet. But I think going the keto route can be very extreme, but sometimes just to kick people into a good eating pattern, it's something I recommend that maybe people try to start with for about a month, because at least you then lower your dependence on glucose, and it becomes a little bit easier to manage.
So, but then, like you're mentioning, some cancers and feed on that fat, and also within within the keto, you also have a lot of glutamine. So, how would you, if that is the first step? I mean, what would be the ultimate?
I don't
diet?
recommend that for certain cancers, like prostate cancer. I don't recommend that, and melanomas, I certainly wouldn't ever suggest people do that. But with a lot of other cancers, that do feed off glucose as a primary source of energy, kickstarting your diet with the keto is not a bad idea, but I don't recommend it for longer than 3 or 4 weeks.
Okay, and so for something like, let's say, prostate, where you're not supposed to do the ketogenic, what kind of diet would you suggest in that place? Because they can't do keto, they can't do any kind of glucose. And with glucose, you're also talking about stay away from even fruits, right?
Yes, but some fruits are lower in sugar than others. So berries, for example, are often allowed in small handfuls with the ketogenic diet, and apples and things in small amounts as well. But I just think that's too extreme, and I'm not a lover really of that type of diet. But certainly with something like prostate cancer, where you have a fat and glutamine-driven cancer, having a low protein diet and going mostly vegan. You can have fish occasionally. I think that's good. It's got a lot of good things going for it with good beneficial oils, and actually the good fish oils will stop the uptake of bad oils. So fish is good, and but even eggs actually have been found to be quite a problem for people with prostate cancer. So doing less than 2 eggs a week is something that I would recommend as well.
Oh, okay, wonderful.
Yeah.
And so, in your strategy, you have what's called a press and a pull.
Pulse.
Oh, I'm sorry. Yeah, press and then also do the push. So,
yeah.
How? Tell me a little bit. But what does press involve and what does push involve?
Well, one is kind of a starve phase, and the other one's more of a kill phase. I've kind of nicked Professor Tom Seyfried's analogies there as to sort of how populations die out. This is sort of something that's been looked at in ecology, and just how certain types of plants or animals will actually die out. And this is what you want to achieve really with the cancer, is to sort of treat it a bit like an alien species that you just want to eradicate. And the thing that Professor Tom Seyfried was thinking about was that if you stress the population with a sort of a lack of food for a while, and then you just bring in some kind of element that just kills them off, it's much easier if you've got the population under stress to start with. So the press bit is really just the starve phase, and then the kill is more just a sort of, it's an easier way to just kill off the cancer once you've got them on the run, if you like. So if you have them depleted of nutrients and feeling kind of weak, it is much easier to kill them off with chemo, radiotherapy. And in fact, I didn't use either of those things when I had the leukemia, I actually used a high dose of a non-steroidal anti-inflammatory combined with a statin and also intravenous vitamin C. And that combination was very good at creating that kill without having to resort to chemotherapy, because I'd already put it under enormous stress with the diet and using those supplements and also the off-label drugs.
And so in the press, I mean, you have the starving, but then also when you're dealing with cancer, there's a lot of kind of cell signaling that the cancer does in order to promote its own survival. How do we deal with those, and why are they there?
Well, what it's doing is it's communicating with its neighbors just to find out. It's all down to sort of nutrient status. It needs to know whether it has the right conditions, the right environment to divide and to create its daughter cells. So if the environment's not there, it'll actually send out signals and create areas of. This is why you get wasting and you get pockets of sort of muscle and fat disappearing in sort of nearby areas to where your cancer is, because the cells send out these signals and cause the body to sort of produce, to sort of break down and provide nutrients to then flood the area where the cancer is. It's very clever. But unfortunately, and this is actually how bacteria work as well. Actually, they have a very similar cell signaling effect where they will affect other areas of the body without actually, it doesn't seem like they're there, but they are. And they communicate with each other. It's a little bit scary, but that's how it does it. But this is a process called autophagy, and you can actually stop this with, there are some drugs that are out there. Hydroxychloroquine or chloroquine sulfate, which is an anti-malarial, is very good. And that's being studied by several researchers to try and stop this process. Dipridamol, which is one of the drugs that I use, actually is very good at stopping some of this nucleoside salvage and the uptake of protein back into the cells. So that was very good at blocking that. So there are various different ones, and there's an over-the-counter drug called loratadine or Claritin, which again is something that will also help block that. It's less effective, but it's useful as an addition, I think, because it's so low toxicity.
So it's interesting. You're mentioning Claritin, and then you have another histamine blocker, Tagamet that you're talking about in the book as well.
Yeah.
And these are obviously, I mean, these are just over-the-counter type of drugs that you can use. So
that's right.
So what? I mean, let's like Tagamet, for instance. I mean, how can that be useful? You talked a little bit about Claritin that will help with some of this abnormal cell signaling, and then Tagamet. What would that do?
Tagamet can be used in different ways. I actually used it as an immune booster. So it was several years after I had gone through my recovery, and I still had a really shocking immune system. I was picking up one cold after another. I probably had about 2 weeks out of 3 where I felt like I was able to, actually no, the other way around, 1 week out of 3 where I felt I could actually behave like a normal person and actually live my life normally. The other 2 weeks I was laid out flat in bed feeling very poorly. So I really had a terrible immune system as a result of all the chemo and everything else that I'd previously had. And it was I used Tagamet at relatively high dose twice a day to try and reverse that effect, because what that does, Tagamet has an effect on what's known as your humoral immune system, and cancer really needs to have your cellular, the one that attacks invaders and pathogens, and that side of your immune system needs to be fully working with cancer, and it gets out of sync. So you get your allergy response goes way up, and then your pathogen response goes way down. So the Tagamet actually switched it back so that I then raised up my pathogen response, and then I lowered the allergy response with it. And this helped to rebalance my immune system. because it was completely out of kilter.
And this is something that with cancer, obviously, especially if you go through chemo, I mean, chemo really destroys the immune system, and obviously with chemo you can't kill all cancer cells, so you need to rely on the immune system to mop up the rest. So then this would be very useful then, I would take.
Well, I don't know that you should be taking... The problem with Tagamet is that it can slow down the release of drugs and clearance in the liver and things, so you have to be a little bit careful about what you mix it with. If you actually look on drugs.com and sort of look at interactions, it does interact with a lot of things, and the sort of that's because it sort of slows down the breakdown in the liver. But having said that, you can use that to your advantage to make some drugs more effective. Mabon Dissolve, for example, you can make more effective by the addition of Tagamet. I'm not necessarily advocating people do that, but a Mabon Dissolve is an anti-worming pill that is being studied as part of an anti-cancer cocktail, and a very similar cocktail to the one that I put together. And it's a simple pinworm medication that's given to kids in the UK. I'm afraid to say you can't get it over the counter anymore in the US. It seemed to go off the market in about 2011, when it was just roughly about the same time it was discovered it had anti-cancer effects. It's all highly suspicious. But anyway, Mabon Dissolve is a very interesting drug in that you can, it has a multitude of effects, but the Tagamet will actually help the absorption and help it get into the system much better. So, it has its uses in terms of helping assist other drugs, as well as being very useful on its own. And Tagamet is very useful also before and after surgery, because you get this altered immune response where you get this massive reaction, and it switches off some of your suppressor cells, and you then don't have the immune system that you need to fight. You kind of it's a really bad situation that you're chopping out the cancer, and yet you're creating an environment with inflammation and low immunity, which will encourage the cancer, any cancer stem cells that are left, to then migrate and find somewhere new to set up camp. So it's very important to try and address, when you have surgery, to try and address all those factors and try and look at ways to reduce the chance of metastasis, which normally happens about 11 months after you have surgery. You suddenly get a peak of mets happening, metastases, either, another site developing cancer. And this is a direct result of the surgery. So, and this is not fully recognized, again, by surgeons as well as oncologists. They're so keen to chop it out, and yet not keen to look at and be proactive enough to try and stop it from having the inflammation, from, having the ability to spread, reducing the immune system. You need to boot it back up again. All of these things need to be addressed. Stress levels as well. Propranolol is another drug that's very useful, and that's a very common blood pressure and stress and anxiety reducing drug that's often given by physicians. So that's actually quite useful pre and post op, and actually that has a lot of similar effects in some ways to dipridamole, which was one of the drugs that I took, which is an antiplatelet drug. But this, they both have an effect on stopping growth factors as well. So they have multiple, all of these drugs have multiple targets in the pathways that cancer uses. And this is what makes them so useful. And it's actually just understanding the pathways that you need to block and then working out the cocktail that you need. It does sound complicated, but I promise you, I have people read my book several times, but it's important. If you have cancer, I think it is really key that you actually understand how it works. I think you're really, particularly if you have stage 4, if you're being told you've got a terminal diagnosis, why shouldn't you do as much as you possibly can to try and save yourself? And this is what I don't understand sometimes with the oncology profession, is they try and put people off from even looking anywhere. And I find that unforgivable, actually.
Yes, especially when you have somebody in front of you that you know that you cannot
save.
You can't save. You know that, yes, I can slow down the process, maybe, but so why stop them then from doing things that are a little bit out of the ordinary, that may have a potential to change the picture, when we know that what the oncologist is going to do has the same kind of outcome as it had for the last 100 that he treated.
Exactly. What is suddenly going to be so different?
Yeah, exactly. That's kind of a sign of not being so smart, that you keep doing the same thing and expecting a different outcome.
Exactly.
Yeah.
It's that classic experiment, isn't it?
Yeah.
Anyway, but and unfortunately, every cancer patient does feel like a guinea pig, because they are.
Yeah. Exactly.
Essentially.
Well, we're going to take a quick break. I'm here with Jane McLelland. You're listening to HealthMade Radio. I'm Dr. Michael Karlfeldt. We'll be right back. Welcome back to HealthMade Radio. I am here with Jane McLelland, and we're talking about revolutionary tools in regards to dealing with cancer. And these are using off-label drugs that you may have, just over the counter, and some supplements, and they can be really powerful in your battle against cancer. So, what are some of your top favorite off-label pharmaceuticals and nutraceuticals that you think that these should people should really know about these?
Okay, all right. Well, my top two, Metformin and a statin. All right, and I know a lot of people hate statins, but seriously, they do have so many benefits for cancer. But the point is that even if you can't see it being particularly useful for your cancer, that it will work in combination. And that's the key, is to actually get the right cocktail, because you need to block different pathways. And if it's not using one pathway, it'll just hitch a ride up another one. So Metformin is another biggie, which is obviously an old diabetic drug that's been around for decades. In fact, it took a while for the US to embrace it. But the UK has been using it since, I think 1950s or something.
So it has a little bit of a safety record.
Totally.
Yeah.
And, it's actually one of the safest drugs out there. It's actually normoglycemic, so it controls your blood glucose and normalizes it. A lot of people think it's hypoglycemic. It kind of got bad press for a long time. It was confused a lot with Metformin, which is similar and actually is probably better for cancer. But Metformin is a really quite safe drug, as long as you don't have type 1 diabetes and you're not overdosing on it or being stupid with it. You need to also take B12 with Metformin. That's another thing that you definitely need to add. But otherwise, it's a really quite a safe drug to be taking. And what that does, it works on several targets, actually, because it not only reduces the glucose that's available to the cancer, it also reduces some of the... Well, it helps to block the growth factor, the IGF-1, insulin-like growth factor, which is a real key driver of cancer in many cancers. And also mTOR, it helps to block this particular pathway of initiating the cell division. So there are lots of ways that it actually works. And the statin, again, will work on different pathways as well. And it's a combination of trying to hit as many pathways as you can with drugs that sort of hit as many at the same time. So you work at sort of trying to block several together.
So those are your top two, and you mentioned then you mentioned with Metformin that it's important to do vitamin B12 along with it. How about with statin? Do they need to do CoQ10?
Well, CoQ10 actually helps the electron transport chain as part of the ATP, the energy transfer. And actually what you need to do is not do that when you've got cancer. It's a little bit different. because you have this altered energy pathway, that's something you need to avoid, I'm afraid. But if you start getting muscle aches, and I mean serious muscle aches and pains, then yes, you can supplement a little bit with CoQ10. But I think it's something that if you really want to get the most benefit, then unfortunately you have to sort of not take the CoQ10 during the time that you're treating yourself. Certainly later on you can resupplement and reboot yourself, because those kind of things are important for regaining normal function again.
And with that, you also talk a lot, so people think that CoQ10 antioxidant, that's great, but you actually want to then stay away from some antioxidants, and also you want to stay away from things like glutathione. Why is that?
Well, that's something that doesn't seem to be readily understood, and I even see a lot of complementary doctors giving intravenous vitamin C alongside glutathione, which completely negates the benefits of the intravenous vitamin C, because if you give it to a cancer patient at high dose, you're trying to make it an oxidant. It actually releases hydrogen peroxide, which will help kill the cancer cells. But if you add glutathione is kind of like your master antioxidant in your cells. And this is what the cancer cell actually learns to use. So as prevention, it's brilliant. If you haven't got cancer, then glutathione is excellent. But unfortunately, cancer will use it. It'll sort of switch to being able to use the glutathione to protect itself from being broken down and killed off. So it has, unfortunately, in very early stages, like a 0 ductal carcinoma in situ in the breast, it's been shown to actually stop it progressing. So glutathione is great, but then any further down the line, the cancer will use it to protect itself from being killed. So it's a tricky one. The whole glutathione issue is a tricky one, because it's also very good for detoxing after chemo and that sort of thing. So it's striking a balance, making sure that you get the appropriate amount of kill and the appropriate amount of starve and the appropriate amount of detoxing. It's the whole thing is a juggling act, and it really requires some very careful monitoring. And I do recommend that everybody gets an integrative doctor on board to help them with this program, because it's not an easy system to try and follow if you're just trying to do it on your own. People do it, and I kind of did it, but I did have doctors helping me too. So
if you find kind of these are the pharmaceuticals that'd be good for me with my type of cancer, and you go on that program, should you just stay on that, or do you need to stay on certain pharmaceuticals for a while and shift to another for a little bit, or how does that work? I mean, do you just kind of...
Traditionally, people think that cancer, you need to shift around and stop it mutating. Actually, if you've worked out the reasons why it mutates and the different pathways it takes, the point is you should block the lot, really, to stop it being able to mutate. So my MetroMap will block pretty much most of the key pathways that it uses to mutate and to resist drugs. So things like, Herceptin or whatever, drugs, people do eventually become resistant to them, or the cancer becomes resistant to them. But you can actually make that not happen by having the right drugs to help. So in fact, actually with Herceptin, if you add, if you type Herceptin and chloroquine into Google, you'll find some research to show that actually, because it's helping to stop the autophagy process, one of these pathways, you actually make the Herceptin last for much longer. So it will stop it from being able to become resistant. So it's just about being able to block the metabolic side as well as the genetic side.
And also that you use things like aspirin a lot. I mean, how does that play a role in when you're dealing with cancer?
Well, aspirin is actually quite a powerful drug. And, I mean, even cancer research are finally doing some research into it. It should really be classified as a cancer drug. We shouldn't really have to do a whole load of 15 years worth of research. We just need to have it classified as a cancer drug so that it can be prescribed by oncologists for people. And particularly some cancers that are very driven by the fatty acid pathway, things like breast cancer, for example. They do respond incredibly well to just a small amount of aspirin every day, a baby aspirin. In the US, that's an 81 milligram dose, and in the UK, it's a 75. And that's enough. In fact, actually, you need to have it in combination with either metformin or with berberine, and that helps to block this fatty pathway. Again, it's a cocktail that's really key. And also, on its own, aspirin has these anti-inflammatory effects anyway, and reduces something called PGE2, which prostaglandin is a bad inflammatory marker that you get. So it has an effect on lots of things that are negative, and it helps to rebalance the body to help fight the cancer. And I think it is seriously overlooked, seriously undervalued, and something that should be given to virtually every cancer patient, unless they have some kind of stomach ulcer or something like that. You need to be obviously a little bit careful when you take your aspirin. Make sure you take it with a meal, and not late at night or anything, and not with alcohol. But most people can tolerate half an aspirin. In fact, actually, it's been shown that if you take it every day for 3 years, you're less likely to get a stomach ulcer. But you just have to keep taking it to get to that point. And the body becomes a little bit resistant to it in terms of bleeds.
And that works differently than if you would use some other anti-inflammatory like curcumin or ginger or something like that. They
also work on the same pathways as well, but curcumin doesn't actually stop the fatty acid. So it does, in terms of blocking certain key pathways. Curcumin does actually work on mTOR, and it works on so it has got some effects on the metabolism and the uptake of fuel, but curcumin is much more a sort of an anti-inflammatory COX-2 inhibitor, so it does work alongside aspirin as well. So all of these things, and inflammation is key. You need to reduce inflammation. Inflammation is an underlying factor in pretty much every degenerative or chronic illness, of which cancer can be classed. It's that you have something called interleukin 1 and interleukin 6, and these are inflammation markers that go up when you have cancer.
Yeah, they drive that process.
Yeah.
Well, Jane, it's been such an honor having you on your show, and what you're bringing forth to the world is revolutionary, and
Thank you.
I truly
I hope I haven't been too sciencey.
You did great. You did perfect, and I really urge all the listeners to get Jane McLelland's book, How to Starve Cancer. It is an easy scientific read, meaning that it is in a storytelling fashion, and it still gives you the tools that you need to start your journey in regards to how to fight your cancer. And so it's an amazing book, and I truly appreciate what you're bringing forth.
Thank you so much.
That is it for today. You're listening to HealthMade Radio. This is Dr. Michael Karlfeldt. Remember, check us out at healthmade.co. Health is what you make it. Health is what you make it. Health is what you make it.